Hello, my name is Zach Timmerman, and I'm a third-year medical student at Michigan State College of Osteopathic Medicine. And today I'm going to be discussing a case on agenesis of the dorsal pancreas, presenting as recurrent pancreatitis. So a little bit about what this is. Agenesis of the dorsal pancreas is a very rare anatomical anomaly. There's a little over 100 cases published in the medical literature. Basically, it's a failure of part of the pancreas to develop. It can be characterized as either partial or total agenesis, and this is based on how much of the pancreas the patients do have. It can present in a wide variety of ways. Patients can be asymptomatic, only have vague abdominal pain, hyperglycemia or diabetes, or pancreatitis, as in this case. So why is this case interesting? First, the patient in this case didn't have isolated agenesis of the dorsal pancreas. He had it in conjunction with a larger disease called polysplenia syndrome, which is characterized by the abnormal arrangement of the abdominal organs. So he had many other anomalies seen on imaging. Second, this case is an example of one of the more severe manifestations of this disease, as many of the other presentations can be more indolent. So in this case, we had a 44-year-old Caucasian male with no past medical history presenting with severe epigastric pain, nausea, and vomiting. It's important to note that he had no prior risk factors for pancreatitis. He didn't drink alcohol or smoke cigarettes, wasn't obese, and his triglycerides were within normal limits. Workup showed a very elevated lipase level, and abdominal CT showed acute pancreatitis, along with agenesis of the dorsal pancreas, polysplenia. He actually had two distinct splenules, intestinal malrotation, and a zygous continuation of the IVC. The patient was given supportive care and discharged after 9 days. 1 week later, he returned with the same symptoms, this time with some additional abdominal distension. Imaging showed worsening of the acute pancreatitis with the development of an early peripancreatic inflammatory mass that was actually causing some mass effect and compressing the gastric outlet. The hospitalization was more extensive as the patient needed extended bowel rest and ended up needing TPN for about a week. He eventually recovered, and after 2 additional weeks was discharged on oral PPIs and pancreatic enzyme supplements. So it was determined that the patient's recurrent pancreatitis was due to the agenesis of the dorsal pancreas. I included some of the key radiologic findings from the case that highlights this. Taking a look at the images from the first admission, you see the inflammatory changes around the pancreas consistent with acute pancreatitis. And then taking a look at both the axial and coronal views together, you see the presence of the pancreatic head, but then the complete absence of the body and tail of the pancreas, which is very interesting. We were unable to determine if this was total or partial agenesis, as you need to visualize the ductal system within the pancreas to definitively make that call. And then in the CT from the second admission, you see the inflammatory mass that the patient developed. The mass ended up becoming more organized and walled off as the patient's symptoms improved, so he ended up being discharged with close follow-up to check on its progression. So what I think is most important about this case, and although it is very rare, the incidence has been increasing with more and more imaging being done. So I think it's important for it to be on the differential for a patient with pancreatitis with no prior risk factors. But the key takeaways are this. If you do have a patient with agenesis of the dorsal pancreas presenting with recurrent pancreatitis, your index of suspicion should be high that the pancreatitis may reoccur. And it's also important to know that this may lead to more frequent hospitalizations as well as longer hospital stays. So that's it. Thank you.